Good day, global citizens. Welcome to another episode of Dr. Fajembola'S Opinion. This is a platform where research meets understanding and legacy. Today, we have a guest researcher who is on board to discuss something entirely different. We have never discussed stroke on this platform before. So this is the first researcher we have on board to discuss stroke, and I believe global citizens will relearn and unlearn concepts they have on stroke. Please do me the pleasure of welcoming Dr. Nicholas Aderinto. I hope I pronounce your name well. I should be flogged if I don't pronounce your
It's fine. It's fine.
I should be queried if I don't pronounce it well.
It's fine. Aderinto, it's fine perfectly. You tried at least 90%. Yeah, so
Okay.
yeah,
I assumed I knew the pronunciation, by the way.
like that's
Okay.
yeah.
Thank you, Dr. Nicholas. Let's go for Dr. Nicholas.
Yeah.
So people won't hang me.
Yes, it's fine. It's fine. It's fine. It's fine. Yeah.
Okay. Thank you so much for accepting the invite and for choosing to share your expertise with global citizens. Today we'll be taking global citizens through stroke, and you are the expert here, and I will allow global citizens to learn from you majorly. Before we dive into the discussion, let's give our audience an overview of the profile of our guest researcher. Dr. Nicholas Aderinto is MD, is a physician scientist and editor whose work is stroke recovery, neurorehabilitation, and translational neuroscience. Has earned international recognition. He is currently pursuing a doctoral program at the University of Utah, where his research focuses on novel neuromodulation strategies to improve functional outcomes in stroke survivors. His work and leadership have made him one of the most visible and influential early career neuroscientists from Africa, contributing to global neurological health. Dr. Aderinto has authored over 100 peer-reviewed articles in leading journals, including the Lancet, Nature, Current Neurology and Neuroscience Reports, Current Treatment Options in Neurology, European Journal of Medical Research, and Clinical Neurology and Neurosurgery. I have more to read, but if you looked at his profile we shared during the week, you're going to get an overview of his full profile. So let us dive now into the discussion. Before we dive in, we usually look at what global citizens are saying about stroke. So I tried to get what global citizens are saying about stroke. I was just getting different types of tweets on stroke, but let's get something on what's the thing about vagus nerve. The first is from Robert Lufkin, MD. He's saying, what if one nerve quietly connects your brain to your heart, gut, immune system, and even how long you live?
Yeah.
Dr. Elizabeth Abuchi explains why the vagus nerve may be the missing link in stress resilience, cognition, and longevity, and how transcutaneous auricular vagus nerve stimulation is turning ancient biology into a practical tool for restoring balance without drugs or surgery. The second is from Craig Brookie, where he's saying the vagus nerve is the longest nerve in your body. It runs from the brainstem all the way down to your gut.
Yeah.
It's the direct communication highway between your brain and your digestive system.
Yeah.
When the vagus nerve is weak or damaged, digestion slows to a crawl. The last is from H. Mom. She's saying in somatic psychology, the chest is where fear is held, grief is stored, stress hormones constrict the breath, the vagus nerve sends danger signals. Subhanallah, the Quran uses the word something like that. She's trying to bring in religious aspect of vagus nerve into the picture.
Yeah.
So now, Dr. Aderinto, you
Okay.
are I'm not even going to lie that I am a consultant. I am not a consultant. I'm not a specialist on neurosurgery, neuroscience. Actually, it's when I just read your profile, I realized like this is your field. This is your niche. And I'm glad this is your niche. And this is not a paper you just stumbled across or by luck you just wrote. So now, Dr. Adenito, what are three words that come to mind when you hear the word stroke?
Okay, so narrowing stroke to three words is quite difficult. But when you hear about stroke, you want to think uh, functional disability in terms of movement. That's something that comes to mind. So when you think of stroke, you think of something that limits people's ability to move around. So I would say weakness, then I would say what we call aphasia. That's sometimes there's speech disorder in for stroke people too. And then the one uh, that really comes to mind again, especially when you look from lower middle income countries or low income countries, like most African countries, is the economic impact of stroke. That really comes to my mind too, even though it's not something that people really think about. So generally, you want to be thinking about weakness of the hand, of the legs in layman term. You want to think about speech disorders, speech dysfunction most of the time. And to me personally, I'm thinking of life after stroke, and it means a lot of economic instability, both to the stroke survivor and even to their caregivers. Yeah.
Thank you so much for that introduction, Dr. Aderito. I may dive towards traditional names because that's what I'm
Oh,
used to.
oh,
Um,
yeah.
but when we're talking about stroke, many people tend to look at it as the end of something, like the end of a sickness, or what comes out of medical condition, something like that. What are the complications associated with stroke?
Okay, so stroke can cause there are direct impact of stroke and there are also indirect impact of stroke. For the direct impacts of stroke, because stroke itself is a large word. There are different forms of stroke. The commonest one that we know is what we call ischemic stroke, and that what happens is there is like a clot blood blocking a blood vessel. So just think of a pipeline in the house and something just blocking it. That means water cannot flow through that pipe, and whatever is at the end of the other pipe cannot get water. So that's what happened in ischemic stroke. And the nature of brain is if brain is not getting the nutrient from blood, oxygen from blood within a few seconds, it dies. And it dies permanently. So that's one type of stroke. The other type of stroke which we see more in younger people is what we call hemorrhagic stroke. So it's just like a burst, the blood vessel burst. So just imagine a water pipe just uh get burst. So that's what it looks like. So depending on the different part of the brain that either of these two happens, that's what gives us the likely directing part of what can come out. But the commonest you see is people cannot walk. They have weakness in their hand or in their leg, depending on the territory. Like I was saying, like the different part of the brain does different thing, and even the arteries they take blood to different part of them. So you can have weakness in the hand, in the lower leg. For some people, it is speech. Some people, even for the speech dysfunction, it could be of different type. For some types, you see people, they are able to speak fluently, but whatever they are saying is just jargon because they cannot understand whatever you are saying to them. For some people, they understand, but you just see that hesitancy in speaking out. So you can have speech disorder. That's also part. For some people, it is even emotional dysfunction because the part of the brain that is affected by the stroke is where what controls emotion. So little things get them into so emotional, they can start crying now, they can get angry. So there are different, those are direct impacts of stroke. For the indirect impact, then you come to the what happens to people after stroke. They cannot walk again. That means it can lead to depression because they cannot do what they used to do. Another indirect impact is people comes down with seizure disorders after stroke because of the numerous neuroinflammatory pathologies that happen in the brain. So those are indirect impact, and then economic impact of it also. And then people cannot make ends meet again because they may not be able to work, integration back to the society, and things like that. So those are indirect impact. So that's how you can view the different impact of stroke on people.
Thank you so much for that, Dr. Aderinto.
Yeah.
We as Africans, we usually have different perceptions of someone having stroke. So,
Yeah.
what are the myths around stroke that we should know about?
Okay, so the number one is, and I think this is getting more revealed now, is that young people, stroke is a disease of the older people. No, recently, even in Africa, we are seeing stroke in the young now. We are seeing stroke in less than 40 years, less than 30 years. So nowadays, anybody can get a stroke. Even young children, they get stroke. So everybody needs to take care of themselves, look at many of the comorbidities that leads to stroke, like hypertension, diabetes. So stroke is not a disease of the older people alone now. In this current age, everybody can get, like, if it's happening in younger people. Another thing that people think is, because of the numerous things, because of the way the brain works, it's difficult for people to get to 100% of what they were after stroke. Now, why that is a myth, there's another myth is once stroke happens, that's the end of life. No, it's not the end of life. So there are two extremes. There are people that sell false hope to people that they can do something and blah blah blah. And there are people that tell people that, oh, once you have a stroke, that's the end of life. No, we've had people that came down with stroke, still living optimally, they're still driving, they are still working, they are still living their best life. It may not be 100%, but they are still living a normal life that unless they tell you, you may not even know that they've had a stroke before. So the myth that stroke is the end of life is not entirely true. Yes. That I think those are the two biggest things for me in Africa because once someone say, "Oh, he has had a stroke in Africa," everybody be like, "Oh, that's the end." No, it's not the end. There are things that can be done. There are recovery. That's why we are studying in the lab, looking for best solutions to get people back on their feet after stroke. And also, the younger population out there should not think that they cannot get a stroke. There are numerous risk factors for stroke, and we are seeing a lot of that now in younger people, even in Africa.
Thank you so much for that, Dr. Aderinto. When I was reading the paper, I
Mhm.
came across different concepts, and I believe when global citizens also come across your paper after this watching or listening to this session, they would like to understand the concept of population. I mean, the term population concepts, context framework. What is this framework about?
Okay, so the PCC framework is basically used especially in scoping a review. We have other frameworks that you can use for other research, like the PICO, we have the PO frameworks too. So it's just more specific. What we are just trying to say is when you pick a topic that you want to do a scoping review on, it's good to define your population clearly. So define your population as much as possible. Okay, this paper is going to look at people who have stroke. What's the age range that you're looking? Are you segregating by gender, like in terms of like stratification by gender? Are you looking at probably Africans alone? So you should be very clear. And then you want to look at the context to what exactly in which framework are you considering whatever topic you're considering, and then the main thing you are studying also the last C in this for example in this paper we're looking at stroke, so that's very important. So you must be able to define the key terms in your topic, Like for example, the main meat of the paper was vagus nerve stimulation in stroke people. So vagus nerve is only what we are considering. Are we considering other forms of brain stimulation? So that's what the framework does. So it's just like a checklist. When you have a topic, I used to tell people when you have a topic, you must be able to identify those three components, especially if you are doing a scoping review. If you are doing, let's say, like a cross-sectional study, we use PICO, that's you must identify your population, you must identify the intervention. The C is for comparison. If we have a comparison group, and the O is outcome. So all of this framework are just always good so that you are not quite vague about your topic, because the first way to miss in research is to not have a clearly defined topic, and that comes for not conceptualizing whatever you want to do very well.
You've shared this aspect of your research with us, and I believe if global students have been following us through previous episodes, there is an episode basically we discussed PICO.
Yeah.
Now back to the main discussion of stroke. What signs show an individual has arm motor deficits?
Okay, so for mental deficit, the first is weakness. Definitely, let's say you can hold a phone before, now that becomes difficult. You can flex your hand before, that becomes difficult. Another thing we see is what we call spasticity. That means when spasticity is just people cannot control what exactly they want to do. So, for example, I may want to flex my hand like this, but because in stroke, one of the issue is there's something we call reciprocal inhibition. What reciprocal inhibition just means is normally as I'm flexing this hand, the other muscle that does the opposite thing is relaxed for me to be able to do this. So what happens in stroke is reciprocal inhibition is lost. So if as I'm trying to flex this, the other muscle that should be relaxing is also contracting. So you see that kind of movement in people that have upper limb. For some sensory sensation loss, they cannot feel sensation as much as they do before. So all of this points to issues of like there could have been a stroke. Obviously, there are other causes of that, but in the context of stroke, those are things that can happen in the arm that could point to the fact that, oh, there is a challenge here.
You've discussed the basics we should know about stroke so far. But
Yeah.
what is the difference between stroke management in high income settings and in low income settings like Nigeria? Now, majority of our audience, why I keep bringing in Nigeria and middle income countries, because majority of our audience are from the global south.
Yeah.
So, what is the difference in stroke management that you've seen as an expert in high and low income settings?
Yeah. So I I think I wrote something in the conversation last year that we can continue using stroke guidelines of high income country and low income country because the realities are different. The human resources are different in low income country. You don't even have enough staff in terms of neurologists, physiotherapists, stroke nurses. You don't have that. It's They have more than enough here, even though they are still saying they don't have enough, but they have more than we do. In terms of the diagnostic capability, MRIs, CT scans, we don't have, they do. So we depend a lot on our clinical acumen to even diagnose a stroke. And then, in terms of the presentation of the patient themselves, and this is linked to financial incapability, before a stroke patient present to us in hospital in low income, like in my country, Nigeria, for example, they are usually past the what we call the thrombolysis window. In America, here, they present on time because they have the ambulance ready, they are more willing to come for. So, those are issues. Then, in the rehabilitative phase two, the level of the rehabilitation that is available here in America and what we have. So those are the different ways things are different. From the patient themselves, the willingness of the patient to come them to the hospital themselves, from the diagnostic capability, the post-stroke rehabilitative ability, the human resources that we have, the financial aspect of things. These are the key things that are different. So you are doing much with little in Africa. In other side, in high income country, you are doing much with much. They are doing a lot, yes, they are doing a lot, but they have all this thing there. And then in terms of the research level of the research output that goes into developing novel therapies in terms of the pharmacological perspective of things, therapeutic perspective of things is quite different. We are doing what we can do in terms of research from middle income countries, low income countries, but it's not enough compared to what they are doing. So these are some of the certain aspects you have to look at in ways stroke management differs from high income countries and low income countries. And hopefully we can bridge the gap one day. Yeah.
Thank you so much. That was what I wanted to say actually. That actually mentioning this because not only global citizens listen to us, also relevant stakeholders.
Yeah.
I'm not trying to, but some people, some leaders, relevant stakeholders, they also watch and also listen to us and to know the gaps that should be filled, especially in low income settings. Now, Dr. Aderinto, from the beginning, we'll be talking about vagus nerve, vagus nerve, vagus
Yeah.
nerve. What is vagus nerve simulation?
Okay, so
In a
Vegas.
way that we can
Yeah,
understand.
so that's so vagus nerve stimulation is, let me just give you a background. In recent years, people have been doing a lot of, we do a lot of brain stimulation and uh, spinal cord stimulation, peripheral nerve stimulation, and the both invasively and non-invasively. So, and there are various nerves that have been of interest over the years. Vagus nerve is quite interesting because it's quite a nerve that I would say multipurpose in the body, quite long and multipurpose. It does different things. It controls the heart rate, it controls gut movement, and in recent years people have been stimulating it because of the therapeutic purposes that have been seen over it. So basically, vagus nerve stimulation or just basic nerve stimulation means you are targeting a nerve and you are delivering electrical current either invasively. Invasively means you are going directly, probably you are opening up the skin and seeing the nerve itself, or you are doing it non-invasively by just targeting the location in the body that you think this is where, like we know anatomically out where this nerve passes through, and then you are targeting them and stimulating them. And what has been seen over the years is by stimulating specific nerves or specific side of the body, they can improve what we call neuroplasticity. Neuroplasticity is just, I don't want to put it in layman term. Neuroplasticity is that the fact that the brain or the nervous system does not regrow, but whatever is left remaining from whatever has happened, they can compensate for the loss that has already happened. So if let's say 60% of something is damaged within the nervous system, the remaining 40%, they can try as much as possible to cover up and be neuroplastic to stretch themselves and be neuroplastic to cover for the deficit, that 60% deficit. That's what it happened. And studies have shown that stimulating this part of the nerves, especially now that we're talking about the vagus nerve, is very useful. And what they do is there are different sites where you can stimulate. You can stimulate from the neck, from the ear, but the most popular one that is currently FDA approved, that's American Federal Drug Administration, is they use the is stimulated at around the year. Yeah, so that's what they do. So it's more like we are delivering electrical current. So that's this field is both electrical engineering, mechanical engineering, medical doctors, physiotherapists work in all of this because you are still dealing with certain electrical physics things, and because you are delivering electrical current directly in at a level that the patient can tolerate, not something out of this world. Yes, so that's basically what is being done in nerve stimulation, and in this point, what does make it vagus is it is the vagus nerve we are targeting, and vagus nerve is just one of the 12 major 12 nerves in the body. Yeah.
Thank you so much, Dr. Aderinto, for explaining it thoroughly. And we know that um, it has a lot to do with our day-to-day activities.
Yeah,
What we've discussed vagus nerve simulation, and we know it's a multidisciplinary approach
yeah,
from what you just explained.
yes.
What roles of vagus nerve should we expect are all happens naturally outside stroke management? Because in the paper, we discussed thoroughly vagus nerve and how it's used for stimulation. What happens outside stroke management?
Okay, so vagus nerve, for example, is what controls when you are coughing. That's one of the functions of is one of the 12 cranial nerves. So when you cough, vagus nerve is the one like that does they work. When something also irritates the back of your throat and you try to split it out so that it won't go through your respiratory system, vagus nerve is involved in that. Vagus nerve also controls your heart rate. When your heart rate is too low, it slows down. When your heart rate is too much, it increases its firing. So it regulates your heart rate too. Another thing it does is it controls the movement of your stomach, how you pass the how like if you eat now, Vegas now controls, oh, okay, it's time for the food to move from your stomach to your duodenum, for example. Another thing that Vegas nerve does is another thing that Vegas nerve does is it controls acid secretion in your stomach. So Vegas nerve does a whole lot of things after stroke, outside of strokes. In fact, Vegas nerve function, even within stroke, is something that people don't expect. So that's not even the major function of it. It's just because nowadays we are just focusing on it in stroke simulation. So it does a lot of things, yeah, in the body. Yeah,
Thank you so much for that, Dr. Aderinto. For those who have listened, if you don't know what a duodenum is, then you should watch our previous episodes because our guest researchers try to explain everything in simple terms. So if you don't know what a duodenum is, you should watch our previous episodes to understand what a duodenum is.
yeah,
Thanks so much for that, Dr. Aderinto. What are key aspects we should know about the arm motor recovery? We talked about arm motor deficits,
yeah,
and now we're talking about recovery. These are key aspects you mentioned, you touched
yeah,
on in the previous publication.
yeah. So the basic thing we've come to learn is when people can still move their hand, we've seen that arm dysfunction is one of the major causes of disabilities throughout the world after stroke. So where we believe that when people can still move their hand, that means they can still walk, they can still function, irrespective of the other limitation that comes with stroke. So, and that's why we focus on arm rehabilitation. So what we do is we want people to be able to use their arm as they were using before for their daily activities, buttoning up their shirt, be able to bathe themselves in the morning. If they are people that type on their computer, want them to do both what we call gross movement and fine movement. And also we want to help them reduce spasticity that usually comes with stroke. So that's basically what we do. The reason why we focus on just arm alone is because we believe when you can recover the arm function of someone, I think you have done them a lot of good after stroke. Yes.
Very well explained, Dr. Aderinto. You talked about you were talking about the arm recovery, the pathway of vagus nerve in the body.
Yeah.
What factors affect VNS management? Now we've discussed also vagus nerve stimulation in low and middle income countries. What factors affect VNS management?
Okay, so in terms of VNS management, uh, the first thing is in stroke recovery generally, individual response differently. So, and that's one of the big thing about you can do something for patient A and it works perfectly, and you come to so there's still variability in all this stimulation. Another thing is one of the key one of the key another key issue is determining, like I told you, the specific parameters for vagus nerve stimulation that works in different individuals. And what I mean by parameters is before you can deliver this stimulation, people that did electrical engineering will know that we have to consider what we call the intensity in terms of amperes. That's a unit of current, I believe. In amperes, okay, should we deliver 5 milliamperes? Should we deliver 10 milliamperes? And then there's something we also call pulse width. So all of these details about how much of this and what is the dose, it really affects it a lot. Another issue currently is how many of these sections do people have to do in a day, in a week, in a year to really get them back. So all of these, there's still variability in those areas. And obviously too, the indirect issues, the money, the pricing of some of this therapy. And in fact, currently, we don't even have all of these therapeutic use available in Africa. So all of this thing we are mentioning is just used here in high income country. Africa, we have not, most of the brain stimulation that has been done in Africa has been just for depression. And I think it's just about 6 countries currently. So our stroke management has not really advanced up to that level in Africa, which is quite sad. But it is what it is currently.
Thank
Yes.
you for emphasizing it is what it is, really. Um, the last question. I really wish I had more questions because the paper was thorough, and I'm glad you explained it in such a way that our audience really understand it after reading the paper. The
Yeah.
last question for today is where do you see post-stroke management in Nigeria in the next decade?
Oh, well, sincerely, this is
Considering the number of neurosurgeons we have, neuroscientists we have in Nigeria, considering that people are also living in Nigeria.
living in Nigeria. Well, I think it was last week. I was just thinking that okay, all these things I'm doing here, when I'm done, and if I feel like I want to go back to Nigeria, where do I even start from in terms of setting up the cost of setting all these things up and funding and things like that? So I was just like
Electricity.
electricity. I was just like I'm building all these things, but I don't think my people can afford to even get anything out of what I'm building currently in my doctoral program. But in all of that, I think there's increased effort lately. We have African Stroke Organization where people are doing a lot of things within the organization to see that stroke management in Africa is improved. In recent time, I think this year also we have the development of the first Nigerian stroke registry. Just for us to even have a database of what is happening in stroke in Nigeria, as big as Nigeria, we never had a stroke registry before. So there are efforts on in terms of individuals. Obviously, for someone like me, even though I'm here, I'm still always thinking about Africa. I'm still always writing about Africa. I still think about Africa. There are other young, developing, other early career researchers like me too, the other ones too, that taking knowledge from high income countries and thinking of, oh, how are we going to go back? So in terms of that, you are optimistic that there is hope in the next 10 decade. But on the other hand, at the level of the policy, the funding from government, that's where things really look bleak because a scientist cannot do much. You can't do more than the funding you have available, the policy backing you up, and things like that. So I would say it's a mix of optimism and pessimism. And I would not want to use that word. I would just say sometimes I feel pessimistic and sometimes I feel optimistic about the whole thing. But I believe that eh, maybe I would say 70-30, optimistic 70%, pessimistic 30% really. Yes, that's what I would say about it. So I believe things will improve. I really, really believe with the effort, but we need a lot of policy backing to get what we need to do done.
Thank you so much, Dr. Nicholas Aderinto, for sharing your expertise with us. Do you have a closing statement? I wish I had more questions
No,
to
no, no,
do
it's fine.
to
It's
make
fine.
paper to gain from the wealth of your expertise. Do you have a
Yeah.
closing statement?
What I would just tell people is I know anything neurology and neuroscience is quite difficult for, especially for people that are not within the medical terrain. Even within the medical terrain, neurology and neuroscience is always seen as very complicated. Yes, but I believe nowadays people are trying to demystify things. If you have questions, reach out to an expert. Try to read content online too from reliable sources and whatever you can do, help us to conquer stroke. Stroke is currently uh, neurological disorders currently has overtaken even cardiovascular disease as a leading cause of disability worldwide. And so we need to do a lot about neurological disorders, especially stroke, especially in the young, so that in the next coming generation, we can reduce the impact of stroke and the incidence of stroke generally. And thank you for having me. You are doing an incredible work, bringing science to people outside of the field, which is quite a good thing to have. Thank you very much.
Thank you so much, Dr. Nicholas and Aderinto, for that explicit closing remark. Global citizens, during the week, we looked at Dr. Aderinto Nicholas' paper. It's a thorough paper on stroke and vagus nerve. So please go through it. As it's mentioned, more investments and more exposure is going into neurosurgery and neuroscience. When he mentioned neurosurgery, I was laughing because I did go through his niche to know that that is where he does his
Uh,
niche. How would I put it? I didn't
yeah,
go through his profile to know that's his niche. That's
yeah,
not where I'll go to. I'm not a fan of neurosurgery.
yeah,
I'm not a fan of neuroscience.
I know it's not.
So at the beginning, I don't know, maybe I started recording it before. I already mentioned that he's the expert, so you should just keep talking on
I
this
know.
field. It's not one of my favorite aspects, even if I love it, I'm a part of medicine. There's some parts of medicine are not my favorite, including gynecology. People get surprised. I'm a woman. I don't like gynecology, even though it's a woman aspect. I'm not a fan of neurosurgery, even though it's the brain.
Great.
And I'm a
Yeah,
medic. So thank you so much, Dr. Adento, for sharing your expertise with us, for spending your time to share your knowledge with us. And I believe global citizens
thank you.
have gained immensely. As we say, we don't gatekeep here, so this is a knowledge you share with your colleague, you
Yeah,
share with everyone you love, your family, your friend. Let everyone learn, and let's build a better and healthier ecosystem for current and future global citizens. So thank you, global citizens. Have a blessed week.
yeah, thank you very much. Yes.